Hello, and welcome to this webcast. Today's webcast is on scrotal mass, anatomy of the testes. And here is the reading assignment from Clinically Oriented Anatomy. Alright, so we see that we have several learning objectives today, but that's only fair because the anatomy of the scrotum and the testes are fairly complex. And here we have the scrotal mass scheme, and so it's obvious that all of the schemes within this genitourinary module will be important for you to know your anatomy, but the nodes under this scheme that particularly jump out at me as being important for anatomy are here on the painful side of scrotal mass would be epididymitis and epididymoorchitis, and then on the right side, on the painless side, we should have hydrocele, varicocele, and we'll also talk about inguinal hernias. Okay, so let's get right into the scrotum. The scrotum is a pendulous pouch of skin, and it is continuous superiorly with the abdomen and the penis, and it's continuous laterally with the thighs, and posteriorly with the perineum. So the scrotum serves to house the testes, and it does so outside of the abdominopelvic cavity. And the reason for this is thought to be that we want to maintain the testes at a temperature that is cooler than the body temperature. In fact, it's supposed to be about 1 degree cooler than body temperature. And this is important. And we'll see that the scrotum being outside of the abdominopelvic contents is one way in which we're maintaining this homeostasis at a lower temperature than the body, but we'll see that there are other mechanisms in place that maintain this temperature change. Okay, so now we're looking at a cross-section through the scrotum and the testis, and this is done in the conventional way. So you're at the foot of the bed, you're looking up superiorly at a patient who's in the supine position, and we'll see that the scrotum and the anterior aspect of the testis is here at the top of the screen, and the posterior aspect is here at the bottom of the screen. That would make this the left testis, and over here to the right we only see a little glimpse of the right. Now, separating the right and the left testis are going to be this, which is the scrotal septum. Now, the scrotal septum is formed by one of the layers of the scrotum, the dartos fascia, and we'll get later to a point where we're going to discuss the layers of the scrotum, but for now I just want you to remember that the scrotal septum is made up of the dartos fascia. Now, the dartos fascia is also responsible for the folds that you see within the skin of the scrotum, so it makes this corrugated appearance of the scrotal skin. Also, here on the skin of the scrotum we see the external demarcation of where we would see the scrotal septum, and the external demarcation is called the scrotal raphe, and this is made by the embryonic fusion of the right and left labioscrotal swellings. Alright, so now we're going to look at the contents of the scrotum, and we're going to talk about the testes. So the testes are the male gonads, and they function for the purposes of production of sperm and for the production of hormones, specifically the androgens. Now, when we look at the testis, we see that it has this fibrous connective tissue capsule right here, and that's known as the tunica albuginea, and it surrounds each of the testes, and the fibrous connective tissue aspect of the tunica albuginea also invaginates as septa to separate each of the lobules of the seminiferous tubules. So here we see the seminiferous tubules right there, and that is the area where production of spermatozoa takes place. Now, as far as the seminiferous tubules go, we'll see that there are about 500 of these in each of the testes, and the seminiferous tubules will then pass by way of the straight tubules into the rete testis. So we see the rete testis right there in the mediastinum, and the rete testis will be this chamber right here. So let's talk about the term rete for just a minute. You may or may not know it, but we've been introduced to this prefix several times already in anatomy. So when we think about even at the microscopic level, we've got the endoplasmic reticulum. If you look at the posterior aspect of your hand, there's the dorsal carpal rete, which is the blood supply there to the dorsum of the hand. We've seen a couple of instances in the body of this concept called extensor retinacula. And then there's also the retina in the posterior aspect of the eye. So what do all of these structures have in common? Well, the answer is that rete refers to a net or a network. So it has different functions, such as when we think about the dorsal carpal rete, it is a net-like structure of arteries in the posterior side of the hand. When we talk about an extensor retinaculum, then you can think of the net as holding something back. Remember, the extensor retinacula serve to hold the extensor tendons down to prevent bowstringing of those tendons when you have extension, say, at the hand. And then the retina itself is a network of blood vessels and neurons. So here in the mediastinum testis, we have the rete testis, and this has more of a net-like appearance, as all of these 500 seminiferous tubules pass by way of several straight tubules into the rete testes, and from there we'll see that the passage of the sperm goes by way of these efferent ductules. And so now we've narrowed it down to only several efferent ductules, and these all lead into, they're the passageway from the rete testis to the head of the epididymis. And the epididymis itself, is really a single coiled duct that leads from the superior aspect, which is the head of the epididymis, and then now we're going posterior, and this would be the body of the epididymis, and then the most inferior or distal portion is known as the tail of the epididymis. And from there, this leads right into the vas deferens or the ductus deferens, which we see here, and we pick back up here at the superior pole of the testis. Okay, so if we have an epididymis, we can talk about an inflammation of the epididymis would be called epididymitis. And now we can see that that's where we are in the... Sorry, my mouse got away from me. There is the scheme. For the scrotal mass side, on the painful side, we have epididymitis. And so that would, of course, logically be an inflammation of the epididymis. And this frequently is going to be associated with sexually transmitted disease, usually with gonorrhea or with chlamydia. Now, it can still happen in a younger population or prepubertal population, in which case you may want to think of the etiology is happening because of a urinary tract infection. So whichever way the infection gets in place, what happens is that there's a retrograde travel of the infection by way of the vas deferens back to the epididymis. And so if we have inflammation of the epididymis, that's epididymitis. Now, that can also be accompanied by epididymo-orchitis. And so the epididymo part refers to the epididymis, of course, and the orchitis part, refers to the testis. So here we have a situation where it's not only an inflammation of the epididymis, but also of the testis itself, and that would be epididymo-orchitis. Okay, so next let's look one layer out from the testis. So we've just discussed the pathway of the sperm through the seminiferous tubules all the way to the vas deferens. Now let's look outside the testis. We said that it was covered by the tunica albuginea, and then if we go one layer superficial or just outside of that, we'll see that in the rest of the testis, other than the epididymis, is surrounded by this tunica vaginalis. So the epididymis lies outside of that tunica vaginalis, but the rest of the testis is covered by this double-layered serous membrane known as the tunica vaginalis. Now, it is double-layered. It has a visceral layer and a parietal layer, and that should remind you of the abdominopelvic peritoneum, and there is a reason for that. We'll get into that in just a second. But let's take a cross-section through the testis, and we can see that this would be the visceral portion of the tunica vaginalis, which makes sense. The visceral portion in the abdominal cavity is the part that adheres to the organ. So the visceral tunica vaginalis is the portion of the tunica vaginalis that adheres to the testis itself. Now, if we follow this around, we see that it's the same membrane, it just doubles back on itself and now lines the interior aspect of the scrotum. So this would be similar to what we saw in the abdominal wall, and so similarly it's named the parietal portion of the tunica vaginalis. And so now we see the two layers, and in between the two layers, right in here, would be a small amount of serous fluid under normal circumstances. Now, we want to remember that that the gonads, in this case the testes, originate embryonically high up in the posterior abdominal wall, and it's a retroperitoneal structure in the posterior abdominal wall. And as the fetus develops, the testes will then descend, and as they do so, they will reach an area where they're going to come through the anterior abdominal wall. And so for that purpose, we see that the abdominal wall will have this evagination, or this outpouching here, which is known as a processus vaginalis. And so these evaginations on either side, the left and right, will form the inguinal canal on each side, making way for the descending testes to enter into the labioscrotal swelling down here. So let's look at this step by step. So this is 4 months of embryonic development. We see that the testes have begun their descent along the posterior abdominal wall, but they haven't gotten very far yet. Now, as they continue to descend, it's tempting to think of the testes as just poking right through the abdominal wall, but that would be a mistake. If we just poke a hole through something, that invites that hole to enlarge, and then structures that aren't supposed to be passing through that hole could do so. So if that was the situation where the testes just popped right through the abdominal wall, just think of all the numbers of hernias that you would have to treat. Instead, the testes, as they descend, will pass through the anterior abdominal wall, but they'll do so obliquely, starting superior and laterally, and as they pass through each of the layers of the abdominal wall, they're coming more and more inferiorly and medially. And as they do so, they're bringing structures with them. So as the passage takes place through the abdominal wall, they're pulling certain structures like the ductus deferens and the nerves and the vessels and the lymphatics, and they're pushing other structures too. So as the testes go through the wall, they're pushing each of those layers, those muscular layers and fascial coverings, and even portions of the peritoneal lining as it goes along with it. And so what should take place is, at the time of birth, the testes should have fully descended into the scrotal swellings, or the scrotum. Okay, so that should take place at the time of birth. Now let's take another look at this from a sagittal point of view, and again we see the peritoneal lining here in blue, and as the processus vaginalis has this outpouching here on the left and right, we see that it's a continuation of the peritoneal cavity, and when it comes down to its final resting place, what we see is that at birth this processus vaginalis should close off, and we see that represented as a dotted line right here. All right, the other thing I want you to see in this slide is this funny word here called the gubernaculum, and the gubernaculum is said to be sort of the trailblazer that leads the way so that the testis knows where to go to get down into the scrotum. And so it used to be thought that the gubernaculum actually was responsible for dragging the testis down into the scrotum, pulling it or reeling it in like a fishing line. So that's probably not precise. It's more precise to think of that this is a differential growth pattern that leads to the testis ending up inside the scrotum. But for me, conceptually, it still makes sense to think of the gubernaculum as being the structure that pulls the testis down into the scrotum. And we can see that by the time maturity has been reached, there's just this little bit of ligament that's adherent, keeping the testis down, the inferior pole of the testis down within the scrotum. But we see also in this picture that the tunica vaginalis here, filled with a slight amount of serous fluid, has now cut off from the peritoneum, and all that's left is this dotted line of the obliterated processus vaginalis. We can see this in another view here of the mature adult here in coronal section, and we can see that the testis has reached its destination within the scrotum. We see several layers of the scrotum, but the processus vaginalis right now has been obliterated, so there's no communication here from the scrotum to the peritoneal cavity anymore. Alright, so now let's talk about the spermatic cord, which is this tubular extension of the layers of the abdominal wall and all the structures that pass between the testis and the abdomen. And so remember that the testis pushes through obliquely, and as it does so, it pushes some layers, and we'll call those the coverings of the spermatic cord, and it pulls other structures along with it, and we'll refer to those as the contents within the spermatic cord. Well, let's look at the contents of the spermatic cord first, and it's unfortunately the case that there are several contents of the spermatic cord. So I found the best way to simplify this for my mind is to think of this as the spermatic cord having 3 arteries, 3 nerves, and 3 other structures. So let's start with the arteries, and really they're the things that sort of make sense that you would find in the spermatic cord. The testicular artery supplying the testis. Now may be a good time to review your anatomy and try to remember where the testicular artery originates from. And I'll just go ahead and tell you that I want you to remember that it comes off of the aorta, fairly high off of the aorta, which makes sense when you think about where the testes developed and the posterior abdominal wall. Okay, so testicular artery is going to be one of the contents of the spermatic cord. Another is going to be the cremasteric artery, and the cremaster muscle is the muscle that is part of the covering of the spermatic cord and is responsible for the lifting of the testes. So we want to maintain that optimal temperature within the testes of 1 degree cooler than the body, but we don't want it to get too cold. So the cremasteric muscle is able to elevate the testis along with the dartos muscle and tunic as well. And together the cremasteric muscle and the dartos can elevate the testis and bring it closer to the body if it gets too cold, or it can relax and lower it down to maintain that 1 degree difference between the body and the testis. Okay, so that was the cremasteric artery, supplies the cremasteric muscle. And then the other artery that's one of the 3 is the artery of the vas. Well, of course, the ductus deferens needs its own blood supply, and the artery of the vas is responsible for that. Okay, so we've got the 3 arteries. The 3 nerves will be the genital branch of the genitofemoral nerve. And the genital branch of the genitofemoral nerve has both a motor and a sensory function to it. So the motor is actually innervation to that cremasteric muscle. So when it is stimulated, the cremaster will rise. And you can also see that with the cremasteric reflex if you're familiar with that. Now, the other function of the genitofemoral nerve is that it supplies a small portion of the sensory distribution to the anterior aspect of the scrotum. The ilioinguinal nerve also conveys sensory information from the scrotum, and some sources will list it as one of the contents of the spermatic cord. But I need to acknowledge that the ilioinguinal nerve enters the inguinal canal from the lateral side and travels with the spermatic cord on its anterior surface, but not really within the spermatic cord. Clinically, this is probably minutia, but I've heard there may be a first aid question that is getting this specific. So we have the ilioinguinal nerve in the inguinal canal, but not really in the spermatic cord. The genital branch of the genitofemoral nerve and the autonomic nerves in the spermatic cord, and now for the 3 other things. And of course, the ductus deferens will be in the spermatic cord. That's the passageway for the sperm, and we've discussed that already. So next we want to address the lymphatic vessels. And that's quite interesting because what we find is that because of the difference in where these structures originate, there is a difference in lymphatic drainage when we compare the scrotum itself to the testes themselves. So the scrotum, remember, is an outpouching of the abdominal wall, and as such the lymphatic drainage is shown by these short blue arrows here. The scrotum itself will drain right to the superficial inguinal nodes, whereas the drainage for the testes is all the way back up to close to where its blood supply came from, and that would be here what's known as the pre-aortic lymph nodes, and they take place on the anterior aspect of the aorta, about the level of L1 to L2. Okay, so that's important because we can then think about the route of infection, if it takes place in the scrotum versus the testes, or cancer, and how the nodes will be affected. Remember, scrotum is going to go to the superficial inguinal nodes, and the testes have lymphatic drainage to those pre-aortic nodes. And then the last of the other three things of the spermatic cord will be this pampiniform plexus, and it's really a plexus of veins. And this is a situation where we have multiple veins that are accompanying that singular testicular artery. There are several instances in the body where one artery is accompanied by two veins, and that situation is called a vena comitatus. But in this situation here, let's take a look at this. If we take a look and do this cross-section through the scrotum right where the red line is, and we look at that in cross-section, we'll see that the testicular artery is right here, and it is surrounded by numerous testicular veins, and collectively they are known as the pampiniform plexus here within the spermatic cord. They will eventually ramify into a singular testicular vein, and I want you to think about how that vein drains on the left side versus the right side. Okay. So the interesting thing about this pampiniform plexus of veins is that it is yet another mechanism of thermoregulation to keep the testes at a temperature cooler than the body. So if we want to keep the testes cooler, then we've got this problem in that the testicular artery is bringing blood right off of the aorta and coming down here, and that blood is going to be at 37 degrees. Well, we don't want it to be, so what we have is this ingenious method of a heat exchange mechanism here. So the warm blood is coming down here through the testicular artery, but the testicular veins, these pampiniform plexus of veins, are already cooled, and so as they return back into the circulatory system, there's this temperature differential between the artery and the veins, and so that's a great way for this heat exchange. So heat is drawn from the testicular arteries and to the pampiniform plexus of veins, so that by the time the blood coming down through the spermatic cord in the testicular artery gets to the testes, it has already been somewhat cooled by the pampiniform plexus. Okay, so let's take a look at the scheme again and look at this this portion here called varicocele. And what we can have with the pampiniform plexus is a situation that's known as a varicocele, and that's due to venous hypertension. And if you get this venous hypertension, then as we've seen in other areas in the body, we can have the dilation of veins, or these varicosities within the pampiniform plexus of veins. And this is classically described on palpation as feeling like a bag of worms. And so now let's look here and see that in this artist's rendition, it's in the left spermatic cord that the varicocele takes place, and that is more likely where that's going to happen. And so now let's think about why. When we think about the fact that these pampiniform plexus of veins are going to ramify into a single testicular vein, and then what's the difference in the way that that vein drains on the left side versus the right side? Well, on the right side, that testicular vein empties right into the inferior vena cava, but on the left side, the testicular vein, remember, enters into the left renal vein, and that left renal vein can be compressed because it has to cross across the aorta to get to the vena cava, and it could be compressed by some of the other arteries or the duodenum. So I want you to think about how this takes place in the cadaver, in the live individual, and remember that it's going to be more likely that you're going to have a varicocele in the left spermatic cord. Okay, and then another of the branch points, another of the nodes of the scrotal mass scheme is here. It's called the hydrocele, and This is another cartoon in sagittal section, and we can see that the processus vaginalis is intact in the normal anatomy, and there is no communication between the peritoneal cavity and the tunica vaginalis anymore. Now that's a normal situation. What can happen though is that this processus vaginalis may not seal off completely, or it may be reopened due to infection or trauma, some situation in which there's an excess of serous fluid produced by the visceral layer of the tunica vaginalis. Now this may or may not communicate back with the peritoneal cavity. If it does not communicate, it's called a non-communicating hydrocele. In a situation such as this, this will probably resolve itself over time as the serous fluid gets resorbed. If, however, we have a situation where we see this on the left, where there's a full communication from the peritoneal cavity all the way down to the tunica vaginalis, this is a more serious situation, because this is now opened all the way down, and we can have free flow from the peritoneal cavity all the way down into the tunica vaginalis. Now this is an opening, therefore, and when we have an opening, there's a potential for a loop of bowel to enter into that reopened processus vaginalis and herniate. And so this would be an example of an indirect hernia. All right, so we've discussed the contents of the spermatic cord, and now let's discuss the coverings, and the coverings as they impact all the way down to the scrotum itself. And so we're bringing this picture back again. Remember, this is the one we used to look at the scrotal septum, and now we're going to concentrate more over here in the zoomed in portion of the wall of the scrotum, and we'll see that here in the next slide. So now we're zooming in even further, and I see a bunch of lines, and it looks like a bunch of layers of the scrotum. Fear not, though. I have this wonderful mnemonic to help you remember the layers of the scrotum. There we go. Some damned Englishman called it the testis. So this is what you can use to remember in order from superficial to deep the layers of the testis. So why do we care about this? Well, let's say in that patient that had the hydrocele that you want to aspirate that serous fluid from the hydrocele. You would want to know which layers the needle passes through to reach that tunica vaginalis to drain that fluid out. Okay, so here we go. Some damned Englishman called it the testis. So the first one should be S, and indeed it is. There's the skin. Next would be the dartos tunic, and that is then going to be followed the next layer deep by the external spermatic fascia, and then the next layer is going to be that cremasteric muscle and fascia, and then we can get to the internal spermatic fascia. So now we've gotten some damned Englishman called it. Now the next T is going to be for tunica vaginalis, and now we have to remember that the tunica vaginalis has both the visceral layer and the parietal layer, and in between the two will be a small amount of serous fluid, except in this guy, because we are aspirating excess serous fluid from this cavity. But let's say that your needle goes too far. It should stop in between that visceral and parietal layer, but if your needle goes too far, it will then pierce through the tunica vaginalis visceral layer, and then the next layer would be that tunica albuginea. And remember that the tunica albuginea is the fibrous connective tissue that then invaginates in to separate the lobules of seminiferous tubules. Okay, so those are your layers of your scrotum, and this is another image to help you sort of figure out where those layers came from as far as the abdominal wall goes, what they're called when they are coverings of the spermatic cord, and how they are layered there at the scrotum as well. This is a nice picture. It's a coronal section. It's from Clinically Oriented Anatomy. It's very colorful. It's also very busy. So if you want a simplified version of that, this is one that was taken out of a book called High Yield Anatomy, and it sort of simplifies. Here would be the layers through the abdominal wall and how they participate in the layers of the spermatic cord and coverings of the testis. All right. That's going to do it for this podcast. If you have any questions, feel free to email me. Thank you so much, and have a nice day.